Okay.
Oh, yes, thank you. Yes. And now we know that the patients with diabetes are as susceptible to COVID as non-diabetic patients, but the risk increases if the patients aren't well regulated. So good control and optimal therapy must be our goal in treating people with diabetes. My colleague, Dr. Pavković, the subspecialist in endocrinology and diabetology, will present you our experience. Goran, can you take this? Yes.
Good evening. My name is Gorana Pavković, and I will tell you something about the management of diabetes during COVID-19 pandemic in our general hospital. These are a few pictures of our beautiful city in Croatia. As you know, COVID-19 and diabetes are clash of the pandemic. On one side, they are infectious disease, and on the other side, they are non-infectious diseases, which we are fighting with. That are, besides diabetes, that are cardiovascular disease, cancers, chronic obstructive disease. In this situation, in pandemic that we are now, the daily lives of the patients with the chronic diseases have changed significantly. COVID-19 pandemic, to its infectious rate and its possibility of severe and even fatal complication, significantly changed our lives, limited many activities, temporarily delayed the treatment of other chronic diseases, stopped communication, and decreased the number of chronic complications in the long run. As we know, a coronavirus infection causes pancreatic damage of the beta cell and activation of the RAS pathway, which causes a new onset diabetes by destruction of the beta cells, and in pre-existing diabetes increases disease severity, higher ICU admission, poor prognosis, and higher mortality rate. Pandemic can worsen the condition of diabetic patients. Due to lockdown, a lot of medical procedures and surgeries were postponed. Patients went to the doctor, emergency services, and hospital less due to fear of COVID-19 infection. Many health conditions remained unrecognized and weren't treated on time nor adequately. Comorbidities increase the risk of complications, and we know outcomes of COVID-19 infection are higher in patients with comorbidities such as diabetes, hypertension, chronic obstructive pulmonary disease, malignant tumor, and these risk factors are associated with the composite endpoint. Underlying diabetes and cardiovascular disease are considered as a risk factor for increased COVID-19 disease severity and worse outcomes, including higher mortality. During the COVID-19 pandemic, tight control of glucose levels and prevention of diabetes complications might be crucial in patients with diabetes to keep susceptibility low and to prevent severe course of COVID-19. Poor blood glucose control is connected to higher mortality risk of COVID-19. This was follow-up of during 28 days on 500 patients with type 2 diabetes and COVID-19 infection showed that survival rate in patients with well controlled is higher than in those with poorly controlled blood glucose levels. So, numerous studies show that better regulation of glycemia improves outcomes in the presence of COVID-19 infection. Well-controlled glycemia is positively correlated with reduction in the relative risk of all causes of death, as well as the consequence of COVID-19 infection. So we know that there is an importance of a good blood glucose control that we achieve by continuous and regular recurrent therapy intake, optimization of current therapy, and with consultations, virtual and by phone, patients with general practitioners and general practitioners with us, diabetology specialists. Evidence suggests that insulins and DPP-4 inhibitors can be used safely in patients with diabetes and COVID-19 infection. Metformins and SGLT2 inhibitors might need to be withdrawn in patients at a high risk of severe disease. Patients with diabetes should follow general preventive rules strictly and monitor glucose levels more frequently, engage in physical activity, eat healthy, and control other risk factors. So when we have a patient with type 2 diabetes that has suspicion on COVID-19 or COVID-19 is confirmed, we can consider of possible metabolic effects of drugs. Metformin can cause dehydration and lactic acidosis in patients if they aren't well hydrated. So patients should stop metformin intake and abide the rules for the days when they are sick. During the disease, kidney function should be closely monitored due to high risk of development of chronic renal failure and acute kidney injury. SGLT2 inhibitors, including canagliflozin, dapagliflozin, and empagliflozin, patients are at a higher risk of dehydration and diabetic ketoacidosis during disease, so patients should stop intake and abide the rules for the days when they are sick. Statin treatment should be avoided during respiratory infection. Kidney function should be closely monitored due to possible development of acute kidney injury. GLP-1 receptor agonists. Dehydration could also probably lead to serious disease, so patients need to be closely monitored. Adequately daily water intake and regular meals should be encouraged. DPP-4 inhibitors. These medications are usually well tolerated and can be continued. Insulin therapy must not be discontinued. Regular blood glucose levels control should be encouraged every 2 to 4 hours or continuous blood glucose measurement. If needed, they should be carefully adjusted so the therapeutic goals are achieved, depending on the type of diabetes, other pre-existing conditions, and general health status of the patient. Our working group of Croatian Society for Diabetes and Metabolic Disorders of the Croatian Medical Association published the recommendations for people with diabetes and healthcare professionals in the Republic of Croatia during COVID-19 pandemic. Treatment goals should be individuals. HbA1c goals for most adults, if they are pregnant, is below 7%. More strict when HbA1c goes below 6.5 is for it can be achieved without significant hypoglycemia or other adverse effect of treatment. In patients with new onset diabetes treated only with lifestyle changes or metformin that have long life expectation and don't have a significant cardiovascular disease. Last three goals below 8%. Is for patients with severe hypoglycemia in the history, limited life expectations, severe micro or macrovascular complications, and long-lasting diabetes in which goals are hard to meet despite education, appropriate blood glucose tracking, and effective dosage of multiple blood glucose lowering drugs. In our general hospital during COVID epidemics, there was a redistribution of the staff and epidemiological recommendations made it impossible for daily hospital to function. Diabetology daily clinic stopped working, peripheral artery disease infirmary stopped working. We turned to individual work. Patients with acute complications of hyper or hypoglycemia were hospitalized. Our communication with general practitioners was through phones, emails, and 5 electronic referrals. Our communication with foster care was through WhatsApp, Viber, and emails. And by that communication channels, we gave instruction on therapy dosage, diet changes, and physical activities. We followed up our patients during the pandemic through A5 e-referral, with consultation without the presence of the patient and through e-prescriptions. In our computer program, it looks like this. When we open the medical chart of the patient, on the right side there is an e-referral. We open it, and in the attachment we have a letter from the general physician, which gives us data about that patient, data that we need to make decision about the therapy change and dose adjustment. We need lab findings, HbA1c, renal function parameters, liver function parameters, urine. We need body weight, height, and BMI, current pharmacotherapy, comorbidities, hypoglycemia, yes and no, and daily blood glucose levels and profiles. Then we complete the data by inspecting the hospital's informatics system, and then we write our medical report the general practitioner receives electronically. The proper number of our patients is located in foster families. So we published the article in which we showed the glycemia control in diabetic patient located in the foster families in Brod-Posavina country during COVID-19 pandemic. In our county, there are 65 foster families in which 108 people were placed during pandemic, and 33 of them were with diabetes, and they had occasionally glycemic control. We contact social service centers to assess us the number of the patient with diabetes, to identify the patient. Then we had communication with the foster homes through Vibers, WhatsApp, emails. They gave us daily blood glucose levels, profiles. We had insight into the therapy, and then we had correction. We observed patients by age, by sex, by BMI, HbA1c. So we looked how good are their regulation of diabetes. Then we observed glucose on fasting and after 2 hours after the meal. Also, we observed the medications they were using and the total number of medications. We observed the values of HbA1c according to the type of the drugs patient is receiving, values according to the number of the medications they used, complications in the sample, number of complications and comorbidities, and the type of complications and comorbidities. As we can see, 100% of our patients had a hyperlipidemia. 65% had chronic heart disease, 60% had cardiovascular disease, and near 97% had hypertension. Number of the complications according to the therapy, and the number of the complications according to the HbA1c. Blood glucose levels are 1 to 4 millimoles per liter is hypoglycemia, 4 to 8 millimoles per liter normal range, 8 to 11 high blood glucose levels acceptable for the elderly with a high risk of hypoglycemia, above the 11 to 15 is hyperglycemia. If the level are this high, more than three times per week, therapy revision is needed, and above 15 is hyperglycemia, therapy revision is needed. We educed foster families how to solve hypoglycemia, symptoms that can appear when the glucose level is under 4 millimoles per liter. If the patient has dementia or cerebrovascular disease, symptoms can be absent, and the therapy is 5 dextrose tablets plus a meal within 30 minutes, 100 to 150 milliliters of some soda, plus a meal within 30 minutes, and glucagon application, and repeat blood glucose levels after 15 minutes. Here is diabetic diet. It's a menu that we give to our patients, a plan for meals. Each meal needs to contain carbohydrates, preferably rich in fibers, proteins, and fat, and each meal should contain fruit and vegetables. There is a plan for menus, and patients need to eat like this. Patients with diabetes have a higher risk of developing infectious disease in cooperation with persons without diabetes. In Croatia, patients with diabetes have 6 vaccines for the patients that's against influenza, against pneumococcus, against hepatitis B, against diphtheria, tetanus, and pertussis, against herpes zoster, and against COVID-19 in the meantime. Patients with diabetes have a 3 times a higher risk for development of invasive pneumococcal disease. Patient with indication for free pneumococcal vaccine in our country are patients older than 2 years who are immunocompetent with chronic diseases, conditions such as heart and lungs, kidney and liver, diabetes, alcoholism, risk of infection of cerebrospinal fluid or leak of cerebrospinal fluid, then persons with asplenia and persons who are immunocompromised because of the disease or therapy. In our computer program, it looks like this. On the end of the medical report, there is a square that you need to fulfill. And then on the end of the medical report, there is our recommendations for the vaccine. To conclusion, we have a great communication through smartphones with our foster families and general practitioners. We also have A5 e-referrals. We individualized rhythm of glycemia control by weekly, monthly, and 3-monthly. We made therapy changes in agreement with foster care families, and we have a great cooperation. We also, in this pandemic, published a handbook for treatment of eternal disease in COVID-19 units in Croatia and in English to help our colleagues to solve some internal diseases and some problems. These are a few pages from it, how to solve hyper or hypoglycemia, diabetic ketoacidosis. And this is our team in our general hospital in endocrinology and diabetology. Thank you very much.